and Lisaponcino. Welcome to UMDF Mitochondrial Medicine 2021. Today, we kick off the LHON programming with 4 excellent science research presentations from around the world. These presentations are made in part through the generosity of these Mitochondrial Medicine 2021 sponsors. Before we begin, a few things to keep in mind. Please mute your microphone upon entry. During the presentations, we ask that you remain muted and turn off your video camera. Under View options at the top of your screen, select Side-by-Side mode to ensure presentations will fit on your screen. We will be using the chat feature as well as raise hand. Please post questions in the chat throughout the presentation. Our speakers will respond in the chat or during the Q&A as time allows. Now, during the Q&A at the end, switch to Gallery View at the top of your screen and turn your camera on if you wish. However, we do ask that you remain muted and raise your hand to ask questions. If you are having technical issues, raise your hand and the staff will try to assist you through chat. Closed captioning is available. If you do not require subtitles, you can hide the subtitles through the menu. Now let's introduce you to today's speakers. Dr. Isabel Lopez Sanchez from the Center for Eye Research in Victoria, Australia. Dr. Giulia Amore from the University of Bologna in Italy. Dr. Anne Chiramello with the George Washington University School of Medicine and Health Sciences in Washington, D.C. And Dr. Alfredo Sadun from the University of California, Los Angeles in California. Our moderators, Dr. Karangia and Lisaponcino, will join us on camera during the Q&A at the end. But for now, let's get started with Dr. Sanchez from Victoria, Australia.
Good morning, and thank you for the invitation to present our work on liver hereditary optic neuropathy, LHON, in Australia. Lhon is a primary mitochondrial disease caused by a point mutation in mitochondrial DNA. There are 3 primary Lhon mutations that are found in the vast majority of patients. The 11778 and 14484 mutations are by far the most common mutations, but there are also other rare mutations that have been associated with the disease. A Lhon mutation is homoplasmic in most patients, meaning that the mutation is present in all the cells in the body. However, Lhon mutations affect a specific cell type in the eye called retinal ganglion cell. Retinal ganglion cells are neurons in the back of the eye, in the retina, that transmit visual information to the brain via the optic nerve. Clinically, Lhon presents as painless, sudden, and irreversible vision loss in one eye, and this is followed by vision loss in the second eye within a year in the vast majority of cases. Some patients may experience spontaneous recovery, and this is particularly the case for younger patients with the 14484 mutation in our experience. Lhon typically affects young, healthy men in their late teens to their early 30s, but it can also present in older men, women, and young children. As a primary mitochondrial disease, Lhon is passed on by the mother. So if the mother carries a Lhon mutation, she will pass it on to all her children. If a father carries a Lhon mutation, he won't pass it on to his children. Nevertheless, all Lhon mutation carriers have a lifelong risk of developing vision loss, and some of them may indeed lose vision. Our recent work aimed to answer a question that we get often asked by people with Lhon mutations. What is the risk of vision loss for someone with a Lhon mutation? to answer this question, we first needed to update our database of Lhon families in Australia. The last time we looked at this was almost 30 years ago in 1992. Back then, there were 20 independent Lhon families in Australia, including 291 affected individuals and 1,750 asymptomatic carriers. So we conducted an epidemiological assessment of Lhon in Australia to update the previous data available from the 90s. And in our 2020 update, we identified a total of 96 genetically unrelated Lhon families. This includes 56 new families, and we updated 40 previously known pedigrees. Since records started in Australia, we found that 620 people have lost vision due to Lhon, including 458 men and 156 women. Currently, there are 350 living individuals with vision loss due to Lhon and almost 5,000 asymptomatic Lhon mutation carriers. With these numbers, we were able to determine how common vision loss due to Lhon is in Australia, also known as the minimum prevalence. We estimated that 1 in 68,000 Australians suffers from vision loss due to Lhon. We were also able to determine that the vast majority of people with vision loss due to Lhon carries one of the 3 primary Lhon mutations, and the 3 primary Lhon mutations account for 87% of total Lhon cases in Australia. We confirmed previously known information that Lhon causes vision loss predominantly amongst males, with almost 3 males affected for each affected female. We were able to determine the age at vision loss in about half of all affected patients to date, and found that individuals who carry a Lhon mutation can convert from asymptomatic carriers to affected patients at any time during their life. Amongst males, vision loss peaked between the ages of 15 and 20. For females, however, the age at vision loss was distributed more evenly. Around 10% of both males and females lost vision at age 10 or younger, and almost 12% of women experienced vision loss at age 50 or older. Current literature reports Lhon as a young man's disease. However, females, older adults, and younger children are also at risk. So the main question we wanted to answer with this study is something we get asked often by patients and their families. What is the risk of vision loss for someone who carries a Lhon mutation? A risk of 50% amongst males and 15% amongst females is commonly cited online by patient support groups. However, we wanted to see whether this was the case amongst Australian Lhon families. We found that penetrance, or the percentage of people with vision loss amongst those who carry a mutation, is highly variable across individual families. Most families were relatively small and had 1 or 2 affected individuals, with a risk of vision loss of about 10%. But we also found examples of highly penetrant families with multiple affected individuals and a very high risk of blindness. On average, amongst the 96 Australian families, the overall risk of vision loss was 17% for males and 5% for females. This translates to an overall risk of vision loss for 1 in 6 males and 1 in 20 females who carry a Lhon mutation. This risk is much lower than commonly cited, and it highlights that we should not blindly quote a 50% risk of vision loss amongst males who carry a Lhon mutation. Our results are important for two main aspects: genetic counseling and the interpretation of clinical trial results. In terms of genetic counseling, we can now provide an updated risk of vision loss for individual families and for the general population of Lhon mutation carriers in Australia. This will help us identify Australian families with a higher risk of vision loss that might benefit from clinical trials, genetic counseling, and even mitochondrial donation when it becomes available in Australia. In terms of clinical trials, it is critical to have an accurate estimation of vision loss risk, as a falsely overestimated risk may lead to an underpowered study or a false claim of efficacy. Finally, I would like to acknowledge the contribution of the key clinicians and researchers involved in this collaborative effort, in particular Professor David Mackey, as well as the Lhon patient community and their families around Australia, and the Mito Foundation for supporting this work. Thank you.
Good morning, everybody, and thank you for inviting me here. I'm Giulia More. I'm a neurologist and a PhD student from Bologna, and today I'm going to talk to you a little bit about a study I've been conducted between Italy and Los Angeles during my residency about Leber's hereditary optic neuropathy in women. I'll try to address some of the questions that are still open regarding this disease in women, such as why are women less affected than men? If women have a different age at onset, or the disease itself is different in women compared with men, and what's the real penetrance of LH1 in women, meaning what's the real proportion of women getting affected among all LH1 mutation carriers. So in order to do this study, you should imagine it divided into three parts. So in the first part, we looked at some factors that are known from literature for being protective or risk factors, in particular toxics, hormones, and other diseases. So we built a specific questionnaire and administered it to a group of affected females and compared the results with a group of unaffected females carrying the mutations. In the second part of the study, we looked at gender differences, so differences between females and males, in particular age at onset and the clinical manifestations. In the third and last part, we revised a large number of LH1 families and calculate again the penetrance, so the number of affected, and compared it between females and males. So let's start with some results. In the first part, we compared 39 affected females with 111 unaffected females. We asked about toxic exposures, and we found that in the affected group, there was tendency in higher use of alcohol and definitely a significantly higher use and duration of smoke habit. So this once again stress the fact that smoke in particular is a known and confirmed risk factor for developing the disease and should be absolutely avoided. Regarding hormonal factors, we know from literature that estrogens, which are the female hormones, may have a protective role. So we asked our women about pregnancies, hormonal replacement therapies, and menopause age. We found that in the unaffected group, there was a higher number of pregnancies. This result is a little bit difficult to interpret because we don't know if the pregnancy, which is a time with high levels of hormones, can have a protective role in the life of a female with a LH1 mutation, or if this result is just due to the fact that unaffected females can lead a more regular life. In the same way, we found in the unaffected group a tendency, so not significant, higher use of hormonal replacement therapies. So this aspect is something that should really be more investigated in the future, because if confirmed that hormones can have a protective role, we could think about some strategy to prevent maybe the disease in women. Regarding the menopause, so the time when hormones level drop, we were expecting earlier age at menopause in the affected group, which we did not found. But looking more closely just at the affected females, we found that a significant proportion, 20%, developed the disease after the menopause. So this period in the life of a woman with LHN mutation should be really monitored closely, because there's some even low probability of getting affected. For what concerns other comorbidities, so other diseases, we found that a significant proportion of affected females had also multiple sclerosis. So 10%, which is higher than the prevalence of multiple sclerosis in general population, where it's about 0.1%. So the association of multiple sclerosis and LH1 is already known. It's called Harding disease. What is not clear yet is if it's just a chance occurrence of two diseases in the same person, or more probably there's some kind of interaction between the two diseases. Regarding other autoimmune diseases, we found a slightly higher prevalence of endocrinopathies, in particular thyroid disease, in all women, both affected and unaffected, which was 22%, a little bit higher compared with the 15 in general population, even if not significant. So again, more studies are needed to see if there's some association among this kind of autoimmune disease and LH1 disease. What was really interesting was the prevalence of migraine reported by both the affected and the unaffected group, which was over 50%, definitely higher than the rate in general population, around 18% in women. So we know that there is evidence of mitochondrial abnormalities in the migraineurs' brain, but we should discuss if migraine itself should be considered a manifestation of the LH1, of being a carrier of LH1 mutation, even without the visual defect. Okay, let's move now to the second part of the study regarding the gender differences. So we compared the age at onset of 93 affected females and 197 males. And we found that women have a significantly older age at onset, so 27 years, compared with 22 years in males. And also that women have a different distribution in age at onset. Since while in males we can distinct a clear peak around 20 years of age, which is the classical type, and a second peak around 40 years of age, which is due to the cases developing after toxic exposures. In women, we can distinct a third peak after 50 years of age, which can maybe be due to the cases developing the disease after menopause. For what concerns the ophthalmological manifestations, we found no significant difference between women and men in terms of visual acuity, visual fields, and OCT parameters, except for a slightly worse visual acuity in the first 5 years of disease in women. So it seems that women, if and when they get affected, can have a worse vision at the onset, but then the visual acuity, the final visual acuity and the visual outcome is the same as men. Let's go now to the last part of my presentation regarding the penetrance. So I revised a total of 127 families for a total of over 2,000 carriers. And we counted 380 affected. So we get general penetrance of 14%, which is in line with the data from literature. And we also confirm the distribution of the three mutation, with 11778 being the most common. After stratification by gender, we found that among all women, 8% were affected, while among all men, 20% were affected. So we got a female to male ratio of 1 to 2.5, which is lower than what expected from literature. So we definitely had more female affected than expected, and this is something that should be considered and known by both clinicians and patients. That was my last slide. I'd like to thank a lot my Italian group and the American group I've been working with. And a special thank you goes to the Patients Association, both the Italian and the American, who helped me a lot collecting the data. I'm really sorry for not being able to participate to the discussion after because of the time difference, but I would be really happy to answer any of your questions by email. Thank you again very much.
Hi, my name is Anne Chiaramelo. I'm an associate professor of anatomy and cell biology and the director of the Mitochondrial program at the George Washington University School of Medicine and Health Sciences. Today I will discuss with you the survey analysis of patient input on the clinical spectrum of LH1+. It is an ongoing study with the LH1+ Global Project to accelerate discovery into patient care. Before I present our key data, I want just to acknowledge the key contributors of that study. Lisa Thompson, who is the founder of the LH1+ Global Project and LH1 Canada, and she has spearheaded this survey project. Then my longtime collaborator, Dr. Andrea Grobman, who is a professor of neurology and pediatrics at Children's National Medical Center. Dr. Martin Newton-Bogard, who is a lead research scientist in my laboratory, and Eliana Grobman, who is an undergraduate student at the University of Michigan. She has been doing her summer research for the last 2 years with us. Those studies were funded by the Department of Defense Discovery Award. So I want to spend a little bit of time on describing the disease LH1+, since there's a lot of misconception and confusion in the nomenclature between the LH1, LH1+, and LH1MS. So, first of all, the LH1+ disease is a maternally inherited progressive neurodegenerative disease with an adult onset. What does it mean to be maternally inherited? It means this is a disease that is caused by pathogenic mitochondrial variant mapping in the mitochondrial genome. Since the mitochondrial genome is solely inherited from the mother, then this disease is maternally inherited. There are two key features that distinguish the LH1 patient from the LH1+ patient. The LH1+ disease has a gender bias with a female predominance. That stands in contrast with the LH1 disease that has a male predominance. Second, most LH1+ patients have vision impairment, but not all. You do have some LH1+ patients without any vision loss or vision impairment. But what they all have in common, the LH1+ patient, is that they all have a spectrum of ocular symptoms. The problem is that those extraocular symptoms appear later than the vision loss. So vision loss is usually the very first when it occurs. It's usually the very first symptom just to show up. And this is what prompted usually the initial diagnosis, clinical diagnosis of LH1. And then when the additional extraocular symptoms start appearing, then there was never any reconsideration on the diagnosis. So you do have a lot of patients diagnosed with LH1 when in fact they are LH1+. So the presence of a spectrum of extraocular symptoms makes the definition of LH1+. So what are those? Below is a list of the most prevalent extraocular symptoms. It's by no means an exhaustive list. So the first one is multiple sclerosis-like presentation, exercise intolerance, mental and physical fatigue, migraine, peripheral neuropathy, tremors, anxiety, cardiac arrhythmia, myopathy, dystonia, bladder spasm, urinary dysfunction, and gastrointestinal dysmotility. The most common, the extraocular symptoms that they all share are exercise intolerance, mental and physical fatigue, anxiety, even in the LH1 plus patient without vision loss. So we cannot say that the anxiety is due to vision loss. And then you have like a mixed bag of extraocular symptoms among all the patients. So you can have patients with just one of them, migraine, and others with a combination of a spectrum of extraocular symptoms. So I believe that now it has been clarified and kind of like proven that the LH1 plus disease is a clinical entity in itself that should be separate from the LH1 disease. As for the LH1-MS, which stands for Lhon LH1 multiple sclerosis like illness, is usually the patients that have vision impairment or not, but essentially have MS-like presentation. So it's a small subset of LH1 plus patients. And the frequency of the LH1 MS is much lower than the frequency of LH1 plus. The next slide shows the demographics of our de-identified survey using the digital platform of LH1 Plus Global Project. The schematic on the left shows the gender distribution among survey participants that really confirm the female predominance among the LH1 Plus patients. We had 65% of the survey participants being female and only 35% of them being male. The graph on the right shows the age distribution of the survey participants. And the majority of the survey participants were 22 years old or older, as expected, since it's essentially an adult onset disease. However, our survey revealed a small subset of participants or patients that are much younger. We found 10 patients that were between 13 and 21 years old, and then 8 patients that were less than 12 years old. So that was really interesting because it was never reported until now. It was LH1 plus disease was always thought just to be like an adult disease, but apparently it can occur in children. And I'll come back to this subset of patients on my very last slide. So then we asked the participant whether they had at least one family member with LH1 or multiple sclerosis. And the schematic on the right indicate that more than 60% of the survey participants answered yes to the question of family history of LH1. Contrast this with less than 20% of patients answering yes to the question of family history of multiple sclerosis like illness. And that kind of makes sense given the low prevalence of LH1-MS. The next slide illustrates the problem that we're having right now, is that most patients with LH1 plus symptoms receive an LHOS diagnosis, even though they have symptoms specific to LH1 plus. And that is shown on the graph on the left, showing that there are 68% of the survey participants and that received an LH1 diagnosis, even though they have LH1 plus symptoms. And only 25% of the survey participants received an accurate diagnosis of LH1 plus. And finally, as expected, less than 10% of the survey participants receive a diagnosis of LH1-MS. So bottom line, there's a lot of patients that are misdiagnosed. So then we wanted just to find out how the LH1 plus patients are essentially diagnosed. And the survey revealed that the majority of them, about 70% of them, were diagnosed initially by an ophthalmological evaluation that was prompted upon vision loss or vision impairment. Usually when this occurred, the patient is referred to a new ophthalmologist that confirm the LH1 diagnosis. But the new ophthalmologist is never going to look the patient as a whole, and then all those extraocular symptoms are not taken into account. The next test that was previously administered was brain MRI, and finally blood test just to get a genetic diagnosis. Below are two graphs pertaining to the muscle biopsy on the left and the skin biopsy on the right. The muscle biopsy on the left shows that there were like about 15% of the survey patients that underwent a muscle biopsy. I'm not surprised by this very low number of 15%, since the muscle biopsy is a highly invasive procedure that requires a general anesthesia, and patients with a mitochondrial disease usually don't fare that well with some general anesthesia, so it's very hard on the patient, takes time to recover, and is quite expensive as well. So it's less and less practice. It used to be the golden standard, but it's no longer. But what really perturbed me is that only 10% of the survey patient got a skin biopsy. And this is what I call a missed, because I think that a skin biopsy would actually benefit, just to have more targeted treatment. Why that? Because first of all, skin biopsy is done in a doctor's office, is not painful, it's done using an anesthetic cream, so it doesn't require general anesthesia or local anesthesia. It's done very quickly, and then it allows us just to derive patient cells and study those cells in terms of the mitochondrial deficit specific to this patient and the patient's mitochondrial metabolic signatures. So when we combine all this data along with a genetic result with next-gen sequencing approach, then we have like a comprehensive overview of the pathological events occurring in this patient, and that will really favor more like a personalized medicine rather than standardized treatment. So this is definitely a missed opportunity. So why is it so difficult for those patients to receive the appropriate diagnosis of LH1+? It's because the phenotypic manifestations of this disease are highly heterogeneous among patients and even among members of the same family. But so that means that those extraocular symptoms vary from patient to patient and family member from member within the family, and that we don't know the mechanism behind. So the graph on the left shows that about 60% of the survey participants answered yes to vision loss, but you can see that there's about 30% of them that said no. So that pool of 30% again didn't fit the profile of LH1 because they didn't have vision loss, and maybe as the extraocular symptoms started showing up later in life, since it's a progressive disease, maybe that led to the proper diagnosis of LH1+. And two prevalent extraocular symptoms we noticed from the survey were the muscle weakness and the hand tremor. And as expected, only less than 10% of the survey participants had seizures. Then we asked them this unusual question whether those patients experienced bladder spasm and had urinary retention dysfunction. And 30% of them answered yes to this question. And in fact, they were even surprised that we asked this question, since nobody even bothered inquiring why they had bladder spasm or urinary retention dysfunction. So this is a very much underreported and unattended clinical symptom. So in terms of the pathogenic mutation or mitochondrial variants responsible for causing LH1 plus, there are seven known ones. And I've grouped them into two categories, the most frequent category and the least frequent category. Among the most frequent category, you have the 1177-8 G2A that is present in 40% of the survey participants, and this is the one that is in common with the LH1 patient. Hence, the confusion between LH1 and LH1 plus. The second most prevalent mitochondrial variant is a 14484 T2C, and the third one is 3460 G2A. And there are four least frequent mitochondrial variants that make less than 1% each. The next slide will show how interesting, in fact, they are, because our survey revealed an unexpected finding is that three of those four rare variants shown here in the blue box, the 14459 G2A, the 15512 T2C, and the 14258 G2A, they actually cause a childhood onset of LH1 plus. So it's an onset that occurs between the age of 5 and the age of 15. So definitely those three mitochondrial variants have a different penetrance than for example, the 1177A to G2A. So there's a different mechanism. So those will be very interesting to study. And that highlights the fact that the misconception that the LH1 plus is an adult disease, when in fact it can be found in a pediatric patient population. So in summary, the LH1 plus disease is a clinical entity in itself that deserves its own criteria and its own diagnostic criteria. Second, there's a lot of phenotypic heterogeneity associated with this disease. And third, the predominant onset is adult onset, but it doesn't exclude there are cases of childhood onset. So I want to thank you for your attention. I'll be happy to answer any question. If you want to visit our website, here's a hyperlink for further information on our study. Thank you.
Good morning. I'm Alfredo Sadoun, and I'm coming to you virtually from my offices in Los Angeles. I've enjoyed very much going to the UMDF and meeting with patients, and sort of wish we could do it again in person, as has worked so well before, but we'll make the best of this. I thank you guys for this opportunity, and particularly the organizers, and most particularly to Lissa Poinsnow, who has done so much to make all of this possible. So, of course, I'm here to talk about Leber's hereditary optic neuropathy. Lissa asked me to speak about LHON as an issue from the patient perspective, and that's exactly what I've proposed to do here. I'll do, in the first half of my talk, some deeper understanding of the nature of this disease so that we can better appreciate the second half of the talk, where I'm going to speak about what each individual patient can do to ameliorate their circumstances. This is the standard slide that says I have no financial conflicts. I'm not paid for doing any of these things. So we know that Leber's begins with a mutation on the DNA of the mitochondria, mtDNA. Therefore, it's inherited entirely through the mother's side. And we know that it interferes with the mitochondrial function, but still there remain some mysteries that are not explained by this. And I think these four big mysteries have propelled me for over the last 40 years to think about this disease all the time. And in 40 years of research, we've actually, I think, satisfactorily answered all four of these enigmas. The first is, why is it that some individuals get the mutation and never lose vision, and other people do? That's called the problem of variable penetrance. The second is, why is there a gender bias by which men are much more likely to lose vision if they have the mutation than women are? The problem of gender bias. The third problem is that of sudden catastrophic loss. If this is a genetic degeneration, let's say like macular degeneration or Alzheimer's, you might expect a bit by bit, many year, many decade cumulative loss. But it doesn't occur that way. It occurs relatively suddenly, often over a course of only a couple of weeks. So it's a catastrophic event. And it does occur in both eyes, usually one after the other. And then finally, why the eyes? Most specifically, why the optic nerve? That's quite remarkable. You've heard me probably say the optic nerve is the canary in the coal mine. But all the cells of the body have mitochondria, and yet it seems to be the optic nerve that is uniquely susceptible to this disease. Much of what we've learned have been from these 20 or so trips that we've taken about once a year, going down to Brazil. This is a picture from one of those early years. I don't look so young anymore. But it has been Brazil, and more particularly the wonderful families there that have worked with us, and the wonderful collaborators from around the world that have worked with us, that have brought much of the knowledge we have about labors that is now considered to be the standard model. In Brazil, we were able to eventually figure out that there were 362 members of this extended pedigree, which made it by far and away the largest well-known family of labors in the world, spanning 8 generations, and beginning about 1861, when a woman immigrated from Verona, Italy, where in fact a branch of the disease still exists. But most of the patients of the disease remain in this rural area clustered between 3 cities about 100 kilometers apart: Victoria, Colatina, and Santa Teresa. And it began when we were contacted through iFund, a wonderful agency, about this asymptomatic mother who discovered the emails and discovered this disease and discovered us, and sent me an email describing her 14-year-old son who had sudden loss of vision in the left eye. She thought it might be genetic because her older brothers had both gone blind in young ages. And she asked us to come down and see if we could intervene before the son lost vision of the second eye. We were able to get her bus fare and brought her to Sao Paulo, where our wonderful colleagues there at the university did the test that proved that she was right. It was 11778 labors. And this is what the back of the eye of her son looked like. Unfortunately, by the time they arrived in Sao Paulo, the left eye had already started to look pale, demonstrating significant disease. But even the right eye had shown swelling of the nerve fibers above and below the nerve, and both eyes had poor vision, only to get worse later on. So we went down to Brazil and we did many things. I'm going to emphasize one set of things now, which was looking at risk factors. And I'd like you to concentrate on numbers 2 and 3 in red. The first is that if you were a heavy smoker, you were about 4 times more likely to have lost your vision for this disease than if you were not a smoker. And for alcohol, it was about 2 times more likely. So that smoking and alcohol already distinguish themselves considerably here as being triggers for losing vision. Other things can be as well. And by the way, smoking and alcohol, if you look over here, you see that it's more than 5-to-1 ratio between the people who've lost vision affected and the ones who carry the gene but didn't lose vision carriers. Now, the nature of this disease is to begin with a central black spot, which we call a central scotoma, which is relatively small, and over a period of a few weeks for that to get bigger and darker, representing this loss of central vision. Then after many months, it just stays bad. And then one of 3 things may happen. The best case scenario, we go backwards in time and it goes back to how it looked initially, where the central scotoma shrinks up. Another good scenario is where a small area opens up, as illustrated here, which we call a fenestration, Latin for window, a little window through which the person can peer and have better visual acuity. But sometimes there's little to no improvement and it stays black throughout. Are there things that we can do to change the odds of one of these 3 outcomes? But before we answer that question, we have to say, what is the biology? Why do things go wrong in the first place? So this is the biochemistry. Basically, there's a series of chemicals in the mitochondria, complex 1 and 2, that pass the electron, like passing a baton, down to 3, 4, and 5. and this generates a number of ATP, normally 5. But in the disease with Leber's, you knock out this particular molecule, complex 1. It can't contribute its electrons, and you only produce 4 ATP, which is not so bad. That's not the problem. The problem is these electrons have to go somewhere, and they go into another set of chemicals, which we call ROS for short. That's reactive oxygen species, and they set up a signal. And we were able to recapitulate this whole concept in a mouse model under the auspices of Doug Wallace at Children's Hospital in Philadelphia. This is published in PNAS, a very prestigious journal. And these mice demonstrated that the amount of loss of ATP and energy in the brain was negligible. This is not about the lack of energy. But they did show that there was an increase in these ROS that was very high, and in fact, I think catastrophic at causing damage, especially to their optic nerves. So this is the cartoon that conceptualizes what I think is going on. The blockage of complex 1 produces these ROS. Extra triggers in the environment, such as smoking or consumption of alcohol in excess, also contributes ROS. Altogether, this is too much ROS. And when you have high levels of ROS, it changes the characteristics of the mitochondria themselves. Their electrical membrane changes, and if it changes to a threshold critical level, a little pore pops open. Through that pore comes another molecule that sets off a cascade of actions that kill the cell. And that these tend to happen where the mitochondria concentrate the most, which is in the eye, in this area we call the retinal nerve fiber layer, as well as between bundles of myelin in the brain, but mostly in the eye. And that's why it happens there. So this answers a lot of questions. Just to summarize, the Leber's causes a block in this molecule complex 1, leads to a small decrease in ATP and a large increase in ROS. Smoke and alcohol add in ROS. The retinal ganglion cells that are in the optic nerve of the eye have the longest stretch without myelin, which protects them. So they're the most vulnerable to these ROS-induced mitochondrial changes. Myelin turns out to be very protective, and most of the brain has myelin, but not that area. So now I leave you with the most important concept here, which is that this mitochondrial mutation that's inherited in Leber's is necessary, but not sufficient to cause vision loss. So that forces us to think, what does it take to be sufficient? And I think that I can summarize it to say one of 5 other factors: nuclear DNA genome, gender, smoke, alcohol, and certain toxins in the environment, such as particular antibiotics. In terms of the nuclear DNA genome, you do inherit some 40 or 50,000 genes from your 2 parents that can modulate the internal environment. So these are environmental factors, but they're internal in the cell. And there are, for example, 2 sort of types of Leber's, which we've been calling type 1 and type 2. Type 1 means that you've got this DNA genome, which is adverse and triggers it by itself. This tends to occur many more times in men than women at younger age, and it can be triggered by other risk factors, but it's sort of an inevitable situation because the internal environment is adverse. But in type 2, these are patients who often are much older age when they lose vision. They tend to be heavy smokers. The loss of vision is slower. And we see on examination that they don't see well, the visual fields are bad, but there's still a lot of fibers left intact. So we call it more function and less structure loss. And this can be reversible because this is an external environment type problem. In terms of gender, as I've alluded to before, women are more often going to stay as carriers and not convert to become affected. Men are more often going to be affected. It depends on the mutation, but in terms of numbers, using just the 11778 mutation, which is the most common, it can vary from 3 to 1 to 5 to 1, with the predominance being in men. In our particular large Brazilian pedigree, about 12% of women and 46% of men were involved, so it's somewhere between 3 and 4 to 1. But there's a second time that women tend to be at risk, and this is near menopause, when they lose the risk factor the benefit factor of estrogen. And so some of you know that I advocate hormonal replacement therapy whenever possible for women about age 50. Smoke. You don't want smoke. Smoke, not just smoking, is very bad. We reported a case in Northern California where somebody who lived near a tire fire, downwind of a tire fire. This was a woman who lost vision, as did two of her daughters, one of them very young. And this is extremely unusual. And they all lost vision about the same time because the smoke was the problem. There was recently something in Paradise, California, a huge wildfire, and it billowed through some populated areas of San Francisco. Um, we've had cases where people who were exposed to the smoke from bad or malfunctioning stoves lost their vision. And so my recommendation is, if you like barbecue, go ahead and eat it. It's not a problem with that. It's the smoke. So make sure that you're not the barbecuer and that you stand well upwind of the barbecue set. High doses of alcohol produce reactive oxygen species. Enough alcohol to give you a sense of a buzz is enough to produce ROS. So if you feel a buzz, it's too much. I used to say, therefore, that one glass of wine a day was probably acceptable because it didn't produce the reactive oxygen species. But I had one patient in particular, when he heard one a day, he actually heard 7 a week. And he comes in and says, I'm only drinking on Saturday, and I save up, and I have 7 drinks on Saturday, 7 beers it was, which it completely was the opposite of my point. That's a dangerous situation where he's creating a lot of ROS on Saturdays. I've revised my advice for that reason and for other reasons. I just say avoid alcohol, because once you've had that one glass of wine, you may not hear my voice in your head anymore saying don't have the second. So perhaps it's best just to avoid it altogether. And I said there are certain antibiotics. This list is obtained by anybody who comes through my office, but it is these 7 antibiotics that are perhaps most likely, because they were engineered by nature to kill bacteria. And hundreds of millions of years ago, billions of years ago, actually, the mitochondria in our bodies came from bacteria, so they have similar chemistry, and what affects one affects the other. So basically, risk factors of which you can change. You can't change the DNA that you inherited in terms of mitochondrial mutation. You can't change your modifying DNA in the internal environment, but you can change the estrogen levels, the smoke, the alcohol, and the use chronically of these antibiotics. And so I advise doing just the general plan is to avoid this. These are sections of optic nerves in our labs. This is normal, mild, moderate, severe, and extremely severe. The dark represents the intact axons, which are everywhere here and only a little bit left there in the extreme case. And even if you can't avoid having the attack altogether, you want to stay on the left-hand side of the scale. So that concludes my talk. Again, I wish I were able to be there with you in person, and I look forward to perhaps doing just that next year. Thank you.
So I'd just like to start off by thanking all of our speakers and everybody for attending today. We now have an opportunity to have a question and answer period, and there have been a few questions in the chat. Some of them Dr. Camillo was kind enough to answer already. There was another question with regards to why is it that some people seem to lose vision and then later on seem to regain their vision? And that's a great question, and I wish I had an answer to it. We don't entirely know why some people do much better. There is some thought that the genetic background in terms of not only the other mitochondrial DNA genes, as well as the nuclear genes which influence them, may be playing a role. But again, we have situations where people from the same family, one person does very well and recovers vision, and another one ends up in a much worse position. So it's still a bit of a black box, and I wish I had a better answer than that for that question. That. Beyond that, there are a couple of links that Molly was kind enough to send out inside the chat. One of them is talking about the mouse model for labors and how it was developed. if you wanted to see that article. And then there's another paper that we published back in 2019 that goes through quite a number of medications and that I provide to my patients that goes over the different antibiotics as well as other medications that have been theorized to potentially impact the mitochondria. The one thing to bear in mind when you start looking at medications is overall, these medications are given to you for a reason. So you have to weigh that against the potential for vision loss. The last thing you want to do is avoid taking a medication that has the potential to save your life. Your vision, unfortunately, doesn't count if you're not around. So you have to be mindful of that. Also, a lot of these antibiotics, the duration of therapy matters. Getting a single dose, if you went into the emergency department and somebody decided you needed an antibiotic and they gave you one of the medications on the list, typically a single dose is something that your body's going to be able to tolerate. It's usually over long periods of time. Doxycycline was one of the questions asked in the list. Yes, it is. And again, it's those prolonged durations that can cause issues. But it's not necessarily of a single one-time episode. There was also a question in the chat about how is it that some people who weren't exposed to alcohol, smoke, or antibiotics also lose vision? And we don't have, I guess, the perfect answer for that. Dr. Sadoun alluded to that somewhat in the sense that he was talking about some of the genetic backgrounds. And genetics are definitely playing a role. When we look at the population from Brazil, the background haplogroup of the mitochondria. So everybody has these different variabilities in their mitochondria, and some of them give a developmental advantage. So people who are in more northern climates have mitochondria that are slightly less efficient because they need to be able to generate heat. And that's something that has been established over several generations that gave a survival advantage. And so those individuals ended up developing mitochondria that ended up producing a little bit more heat. They ended up having a slightly different conformation. Other groups have different conformations depending on where they are. And based upon that, that seems to play a role. And so as Dr. Sadoun suggested, there seems to be this group of individuals, which we term type 1s, where the vision loss seems to happen. They have a genetic predisposition for vision loss. There are also these type individuals who fall under a type 2 category where the vision loss seems to happen later on in life, and it seems to be related to an accumulation of the toxin exposures that happens. So there was a question in the chat with regards to an individual and seeing a LH1 specialist. I think I'll leave that question to Lissa and give an answer from the patient's perspective as opposed to from the physician's perspective.
Sure. I would say that from the patient perspective, there's a lot of good reasons to having a connection with an LH1 specialist. What happens is you get the diagnosis and sometimes you think, well, that's all I need to know. But then life goes on and you start having questions and it happens suddenly and you wonder, is this safe or is this dangerous or is something happening here? And if you have that relationship established, then you can get answers. So I personally think it's extremely valuable and important to have an established relationship with an LH1 specialist.
Thank you, Lissa. And Dr. Camillo, there was a question in the chat about CRISPR and Cas9. I was wondering if you would have something that you'd like to comment about regards to that.
Sure. So CRISPR is a great technique if you have a nuclear mutation, but if you have it in a mitochondrial genome, then you're a bit out of luck because the mitochondria cannot be CRISPRized. I don't know if it's a word, but that gets it. So I think that it's it depends which mutation you have, but most of the mutations are in the mitochondrial genome, so it's not applicable right now. Doesn't mean that it won't be applicable later, and I think it will be a different technology.
And I guess there are also some questions going back to your talk, Dr. Canelo, about LHON and Parkinson's disease.
Mm-hmm.
And I'm curious to hear your comments with regards to that.
Yes. Hi, Katrina. Hi, Katrina. So yes, that's a good point. And in fact, it's because there's some kind of Parkinsonian-like movement in LH1 plus or LH1 MS, but there are differences. I mean, Parkinson is due to the degeneration of dopaminergic neurons. That's not the case in LH1 plus. So they will have different brain MRI outlook. So subclinically, maybe it could be confusing, but no. After that, I mean, when there's like a radiological finding, no.
Thank you. And there's also a question about women being the only ones that can pass on LH1. And for the most part, that is correct. There have been a couple of case reports in the literature of sperm being able to carry viable mitochondria onto an egg. But the pedigree analyses that Dr. Canelo shared, as well as what we've seen in Brazil, it follows the maternal line.
That's right. I think that the case you're referring where there's a paternal transmission is because there was like a mutation in the ubiquitin pathway. So a few paternal mitochondria were not degraded when the sperm fertilized the egg. But you have just to see that also the sperm comes with very few mitochondria compared to the egg. The egg is what I call the Michael Phelps of mitochondria. I mean, it's about like 500,000 copies. So those few paternal mitochondria might not resist the heavy punch from the maternal mitochondria, but it only takes a few. And then
absolutely. And there's also another question, Dr. Camillo, that what is the difference between LH1 plus and LH1 MS?
I'm so glad. I was waiting for this question. So you have just to see right now it's a spectrum. So we have a spectrum at each extremity. One extremity we have LH1, the other extremity we have LH1 MS. So those are the most two extreme. And in between, you have a whole range of phenotypes. And so LH1 plus and LH1 MS are nearly two different diseases. LH1 MS patients have multiple sclerosis-like presentations, meaning white matter lesions that LH1 plus do not have. And they also have some specific markers, some inflammation markers, and so forth. So it's pretty. It should be a pretty clean-cut diagnosis. It should be. But LH1 plus and LH1 MS can share some phenotypes as well, like vision impairment, extreme fatigue, exercise intolerance, anxiety, a lot of anxiety, and gastrointestinal dysmotility, muscle weakness, peripheral neuropathy. But there are some characteristics that only the LH1 and MS patients do have. This is the white matter lesions.
Absolutely. And there's another question about LHON and eye pressure. And for the most part, LHON is not shown to cause an increase in intraocular pressure. The issue with eye pressure is the eye is a sphere. And in order to maintain that spherical shape, it needs to be pressurized. That's what allows the eye to optics in the eye. So the camera doesn't work well if the eye becomes deflated. The focal length of the camera, the image doesn't show up correctly on the retina. So it needs that shape and it needs to maintain that shape. So in order to do that, the eye produces fluid, and that fluid goes into the eye and then subsequently gets drained out through the venous system. And so you have this cyclical production and drainage from the eye. And usually what seems to happen in patients where their eye pressure goes up The eye itself produces fluid at a very constant rate, but the drainage system becomes blocked for some reason. Now, in patients with labors, you've lost part of the optic nerve. And everybody, regardless of whether you carry a Leber's mutation or not, loses part of their optic nerve with age. The question is how quickly you lose part of the optic nerve and how long you're planning on living. If you live to be about 200, you will have lost vision with regards to just normal attrition of the optic nerve. So if you have a head start with labors, then you're in a position where your nerve has lost a large number of fibers. And then it becomes a judgment call with you and your ophthalmologist to decide whether or not you're continuing to lose fibers as a rate that is greater than what you would expect for normal attrition, and also at a rate that is greater than what we would anticipate for somebody with labors. And at that point, the only real treatment that we have to offer is to consider reducing the pressure inside the eye. And fortunately, we have a lot of good medications to be able to do that. They are quite cumbersome in the sense that the vast majority of them require you to take an eye drop at least once per day. But at the same time, with glaucoma studies and other studies, we have good evidence to say that they do work and they reduce the risk of further loss 5, 10, 15 years down the road. And so it's a match between the individual's age and circumstance, the optic nerve, the pressure inside the eye, and changes that have been happening over a period of time before you can end up saying whether or not managing the eye pressure is necessary.
Could I ask a follow-up question on that?
Yeah.
So have you noticed whether there's an increase in prevalence of glaucoma among LH1 patients?
So glaucoma becomes very difficult to quantify in patients with LH1 because of the loss in the optic nerve that has already happened. You can miss subtle changes like that. So I do certainly have individuals who have glaucoma or have progressive optic neuropathy, I should say, not necessarily glaucoma, that we treat like glaucoma. But I don't typically encounter individuals, and I don't know of any good study that has looked at the number of individuals who have labors and have had a high intraocular pressure to start off with, which would be under the category of a classical glaucoma.
Right, so no pediatric glaucoma?
Not typically, no.
Okay, thank you.
Great question. Okay. And so,
Yes,
Lissa, would you like to handle a question about a database of affected individuals?
Sure. So there are kind of multiple ways to approach the question about, so the question says, is there a database of affected individuals? And we're wondering in terms of any trials that might be enrolling participants. So there's currently sort of a casual way of tracking patients, wherein, as many of you know, I work hard to know as many people in the LH1 community around the world as I can, and strive to connect people near each other or similar in age or mutation or anything else. And that's come in handy as there have been any number of clinical trials over the last few years where they've been looking for patients to participate. So we've been able to help get people connected, patients to trials. So that's been really helpful and useful. In terms of going forward, some of you sat in on the UMDF talks yesterday, or you might want to watch some of the UMDF talks going from yesterday, and they'll be posted and available throughout the month of July, and there'll be more information going forward. But one of the great things about this LH1 community being part of the broader UMDF community is that we can collaborate with them on their initiatives, and they're working on a new database called Mitoshare, And they have a planning team that I'm a part of, and they're collecting email addresses now, and they'll be launching it soon. But that will be another opportunity and another place to collect data for going forward. So more to come on that. Great, good question. And also getting people into a database is a big project. So if anyone in this community listening to this is interested in that topic, know that when that database is open, driving people into it is something that takes a lot of time and energy. So if anyone has time and energy that they'll want to help make that happen, please connect with me at some point, because it'll take effort. Sorry, Dr. French.
No, not at all. And thank you, Lisa. And I guess what I would add to that also is, if you are not in the US, certainly getting involved with the UMDF is important, because it's a very large organization. And given that I split my time between Canada and the US, I can say that it's much easier to get in to see somebody in the US than it is in a lot of other countries, if you have the means and the ability to do it. The local societies, though, like LHO in Canada, the LH1 group in the United Kingdom, there's another group in Italy. Each one of them also seems to manage their own set of databases in a similar way. And being part of that as well would be helpful, because that supports your local physicians. If there are studies or treatment trials, that gives you a way to plug into them. And so I think being involved in both is important. It's the next question that we have. Is to Dr. Carmelo. I don't know if you can necessarily answer this, given that it's very specific to a patient, and it's kind of hard sometimes to answer specifics without having the full picture. But
so the question is, my son is heteroplasmic, and my other children tested negative for the same mutation in blood. Should my daughter get tested by a muscle or skin biopsy prior to having children? First of all, NO for the muscle biopsy, unless you want to suffer, and no. So NO, it's going to cost you an arm and a leg for nothing. So I think right now you can have like a blood test, buccal swab. We can also test from urine as well, because we shed epithelial cells in there. So there are better ways and less painful. And so now you tell me you have a son that is heteroplasmic. I don't know which mutation we're talking about. And the other children tested negative. So my question here, they tested negative by blood, but using which technique? That's the key question. How sensitive was the technique? So sometimes, they have a very low percentage, and then it's declared like not detected when actually it's there. So I try just to be very conservative, and I want to see all the data usually. I just don't like when someone set up the threshold on my behalf, because like 5% might not look much for a biostatistician, but it can be a lot for a patient, because that can be seen as a risk factor. Like we heard this the concept about with in other talks. So I don't know what it means. Mutation is that odd and has been seen in Leigh syndrome. That I don't know what that means. So unless the person who asked the question can clarify what odd means and which variant are we talking about. I imagine that it means that it's not so frequent variant. Perhaps that's what it means. And if it is a case, doesn't matter frequent or not, for you it's 100%.
I think that the mutation in question is 3890. And when she says that, I think that's what she means is super rare, because 3890, I think, is a super rare mutation.
A super rare mutation, what does it mean? It means that it's not frequently encountered, but for the patient it's 100%. So that's what matters. So having a super rare variant means that there's very little known about this pathogenic variant, and then we don't know the influence of the nuclear genome, the epigenomics, the impact of environmental factors like we heard, alcohol, smoke, or not smoking, smoke, and other, depending, for example, what type of profession you have. If you work with chemicals, I don't think that would be highly recommended. So that's a problem of having a super rare variant. Usually we like those super rare variants because they're not very much studied and there's so much to learn from them. And that circles back to the original question that you answered, Lisa, about the natural history of the disease. That is either LH1 or LH1 plus. I think it's critical just to have like an accurate natural history of each disease, and that is lacking.
Agreed. And certainly it would be very helpful for us, both from a clinical perspective as to be able to counsel patients as well as to understand the disease better.
Yes.
I think we have reached the end of our session time, and there were just a couple of announcements I wanted to make. We will still stay on the call for a little bit longer to try and answer a few more questions. But Dr. Sanchez was kind enough to give a presentation. Unfortunately, it's about 2 or 3 o'clock in the morning in Australia right now, so she wasn't able to join us. And she does have her email address that Molly will share inside the chat. If anybody had any specific questions for her, she would be happy to discuss them with you. In addition to that, Dr. Sadoun also sends his regrets. Unfortunately, he's at another commitment this morning, but he will also be joining LHO in Canada on the 12th of July for a session talking about some of the therapies and the recent clinical trials with regards to labors that some people may be interested in. And I encourage you to look at the LHO in Canada website to find out more information about that. And Molly will be also posting some information with regards to that as well in the chat. And outside of that, Alyssa, are there any other issues that you would like to cover before we see what else we can cover in the chat? For people who have to go.
Did you talk about the study?
No, I did not. Thank you for the reminder. So there is one other study that we are also working on right now, and that study is looking at some of the non-vision loss related visual disturbances that individuals have with labors. And this can happen in individuals who have vision loss. And we're trying to get a better sense of how common it is. And so there is a survey that Molly will be posting inside the chat that looks into this, and it's a validated questionnaire that covers some of the features that we're looking for and then goes into more detail depending on whether or not you meet those criteria. And unfortunately, the link is rather cumbersome. So there is an email address, lh1study@gmail.com, if you'd like to find out more information about it. And if you need some assistance completing the survey, just email and somebody will be in touch with you. Thank you for the reminder, Alyssa.
Could I make a point on that? I mean, is that we also with Lisa Thompson, we have like an ongoing survey just to evaluate the impact of COVID-19 and COVID-19 vaccine on those patients, because it's a big black box. So everyone say you got to be vaccinated, understand that, but we want just to learn more about the experience that patients had receiving a specific vaccine and which vaccine they received and what were the symptoms, the immediate symptoms and the long-term symptoms after being vaccinated. So hopefully people will participate in that because it will be very informative, such that we can pass along the information to clinicians.
Excellent. And I think Molly has just posted a link to that survey as well in the chat. So we can, I'm not sure, Dr. Kamel, if you have a little bit more time, perhaps we can take a few questions from the audience directly. If somebody had something that they would like to ask, maybe they can raise their hand and the moderators will make arrangements for them to be able to be unmuted, and then we can answer their questions.
Yeah, I'd be happy to.
So there was a comment with regards to the LH1 Canada website. The link will be going up on the website. I just encourage you to check in with it a little bit later on. And also there is a registration site on there where you can register with your email address, and they will send you information with regards to the presentation as well, if you are interested in finding out more.
I'm not seeing any raised hands, so we may be good. If anyone does have a question and they just want to unmute and ask, we can let one or two of those happen too. And if not, we're good. I just want to give people that chance to speak up if they wanted to ask a question verbally.
Well, they can always ask a question by email. Right?
Perfect.
I'll be happy just to answer those emails.
Perfect. That's great.
Well, thank you, everyone. And we will end this session, and we will hopefully see everybody in person at the next UMDF.